What is arrhythmia? Arrhythmia is any abnormality in the cardiac rate or rhythm. Now, what are the common types of arrhythmia we know? Anything? Any arrhythmia? Which type of bradycardia? It can be sinus bradycardia. It can be different types of atrioventricular blocks, first degree heart block, second degree heart block, and the complete heart block. So, any other things? Atrial flutter, atrial fibrillation, junctional tachycardia, ventricular fibrillation. These are the common arrhythmia that has been encountered in your physiology class, right? So, coming to the antiarrhythmic drugs, what are they? These drugs basically are used to prevent and to treat cardiac arrhythmias, that is irregularity of the cardiac rhythm. Now, arrhythmias are one of the important cause for sudden cardiac death. Not all arrhythmia require therapy, only few of them require the therapy. Abnormal automaticity or impaired conduction or both, these are the cause for arrhythmia. We will be coming one by one. What are the important causes of arrhythmia? It can be ischemia related, it can be due to electrolyte imbalance, it can be due to pH imbalance, mechanical injury, myocardial stretching due to heart failure, neurogenic and drug influence. Now, this is a diagram of the heart. There is a SA node in the right atrium, this is a AV node, this is a bundle of His dividing into the right and left bundle branch and later going to the later developing Purkinje fibers. Now, this is a cardiac action potential. We know is the basically is the phase 0 that occurs due to the opening of the sodium channel. This is a phase 1, phase 2, phase 3 and phase 4. Phase 1 is for fast sodium channel opening. There is influx of sodium. Phase 1 is because of the notch, it is because of the closing of the sodium channel. Phase 2 is because of the opening of the calcium channel. Phase 3 because of the opening of the delayed rectifier potassium channels. And phase 4 because of the action of sodium and potassium channel and the sodium potassium ATPase pump. Now, mechanism of the cardiac arrhythmia, generally 3 important mechanism has been elucidated. Number 1, enhanced or ectopic pacemaker activity. Number 2 is number 2 is after depolarizations leading to triggered arrhythmia, and number 3 is re-entry. What do we mean by enhanced and ectopic pacemaker activity? We all know that there are different pacemaker cells in the heart that include SA node, AV node, bundle of His and basically bundle of His and the right and left bundle branches. Now, basically as the SA node has got the highest pacemaker activity, so the impulse generation occurs from the SA node. But for any reason, if this automaticity is enhanced in the SA node or say in the other pacemaker cells, then that other pacemaker cells can take over the cardiac pacemaker activity, like in case of junctional tachycardia. So, cardiac arrhythmia can be due to enhanced pacemaker activity, ectopic pacemaker activity. If the normal cardiac cell, not the pacemaker cell, develops pacemaker activity, we say it ectopic pacemaker activity. Now, why these pacemaker cells show pacemaker activity? Because they are showing diastolic depolarization in the phase 4. So, the slope of phase 4 depolarization may be increased pathologically in the automatic fibers, or such activity may appear in the ordinary fibers leading to ectopic pacemaker activity. Number 2 is after depolarization. Now, what do we mean by after depolarization? We all know This is a cardiac action potential. Now for any region, if when the cardiac cell is in the action potential, there is another stimulus coming in, so that can lead to some activity or showing. You see, this is a cardiac action potential here, and supramaximal stimulus is applied here. So this cardiac cell is showing again the activity. This is called after depolarization. Now we know that within the absolute refractory period, even the supramaximal stimulus cannot act. Now after the absolute refractory period, in the middle of the phase 3, if a supramaximal stimulus acts, the cardiac cell can show action potential. This is called early after depolarization. And after the end of the absolute refractory period and within the effective refractory period, if the threshold stimulus act, that leads to delayed after depolarization. So these are secondary depolarizations accompanying a normal or premature action potential. It can be early depolarization, early after depolarization, or delayed after depolarization. And finally the re-entry. Basically in the re-entry, an accessory pathway develop. Now this pathway, they have got the refractory period in the accessory pathway is very small. So that what happens when an impulse arises, because of availability of the low refractory period in the accessory tissue, the impulse passes through this pathway and find this pathway, which was a normal pathway, to be excitable. So it shows circus type of movement, that is, we call it re-entry phenomenon. And from this, even in spite of absence of stimulus, there is regular generation of impulse. The important cardiac arrhythmias can be extrasystole, can be atrial or the ventricular extrasystole. They can be paroxysmal supraventricular tachycardia. In paroxysmal supraventricular tachycardia, there is atrial tachycardia 150 to 200 per minute with 1:1 AV conduction, atrioventricular conduction. Atrial flutter, where atrial rate is more than 200 and there is physiological 2:1 to 4:1 or higher atrioventricular block. Atrial fibrillation, ventricular tachycardia and torsades de pointes. Ventricular fibrillation and atrioventricular block. So these are the important some of the ECG basically findings. This is a normal cardiac rhythm. In the premature ventricular ectopic, you see it's a different rhythm with widened QRS. So it's a ventricular ectopic. In paroxysmal supraventricular tachycardia, it's a normal complex tachycardia with regular heartbeat. In the atrial fibrillation, you see there is irregular heartbeat and absence of P wave. Atrial flutter, there is a sawtooth appearance, and here basically we are seeing variable AV conduction. Atrial flutter with 1:1 AV conduction, monomorphic ventricular tachycardia, white complex tachycardia, absence of P wave, and the basically the QRS complex are similar. In the torsades de pointes, you see the variable forms of QRS complex, so it's polymorphic VT. And ventricular fibrillation, we cannot make out the QRS complex. Now classification of antiarrhythmic drugs. A lot of antiarrhythmic drugs are available based on the blockade of the channels. They have been classified into class 1, class 2, class 3 and class 4. It was first done by Vaughan Williams and Singh in 1969. However, certain antiarrhythmic drugs do not fit in the class system, like adenosine, which is the drug of choice in paroxysmal supraventricular tachycardia, does not come under any of the class. And a drug in one of the class can have additional action of other classes, like sotalol is the beta blocker included in class 2, but it also shows class 3 property. So antiarrhythmic drugs classes 1, 2, 3 and 4 are there. In class 1 there is class 1A, class 1B, class 1C. Class 1 is sodium channel blockers, class 2 is beta blockers, class 3 is basically potassium channel blockers and class 4 is calcium channel blockers. Now class 1A, 1B, 1C has been divided according to the recovery of the sodium channel. So class 1A, they moderately decrease DVDT of the zero phase. So sodium channel recovery is in between the class 1B and class 1C. Examples are quinidine, procainamide, disopyramide. Class B, there is quick recovery of the sodium channel, less than 1 second, lidocaine, mexiletine. And class 1C, there is very slow recovery of sodium channel, propafenone, flecainide. Coming to the beta blockers, class 2, propranolol, esmolol, sotalol. Sotalol has got additional class 3 property. Class 3, they are potassium channel blockers. Now we know in the phase 3 of the cardiac action potential, it is basically it happens because of potassium channel opening. Now as they are blocking potassium channels, delayed rectifier potassium channels, the action potential duration is prolonged with this group of drugs. So these agents widen action potential, they prolong repolarization and effective refractory period. Amiodarone, dronedarone, dofetilide, ibutylide. Calcium channel blockers, they include verapamil and diltiazem. Now note, class 1A agents have class 3 property also. Propranolol has class 1 action as well. Sotalol has got class 2 and class 3 action. Now in addition, for paroxysmal supraventricular tachycardia, adenosine is a drug of choice and digoxin can also be used. So these are antiarrhythmic drugs not included here. For atrioventricular blocks, we can use anticholinergic, atropine, we can use sympathomimetic, adrenaline and isoprenaline. Digitalis is used in atrial flutter, atrial fibrillation and PSVT to control the heart rate or ventricular rate. Now coming to the class 1 drugs, we know these are sodium channel blockers. So they have primarily local anesthetic action and these drugs also show antiarrhythmic action. They reduce the phase 4 depolarization in automatic cells. Now this is a sodium channel. Sodium is the sodium channel in closed state. The channel is closed, so sodium does not enter the cell. Now when there is voltage change, the channel opens up and sodium influx occurs. It is in the open state. Now after the opening of the sodium channel, when sodium passes through, for a short time the channel is inactivated and at that time even the voltage change can't open the sodium channel. So inactivated sodium channel. Subclass 1A, they block the open state of sodium channel and moderately delay the channel recovery, and they block the sodium channel particularly at higher frequency. So only the partially depolarized cells are affected more, like in case of digoxin toxicity and ischemic cause. These actions serve to extinguish ectopic pacemaker activity that are responsible for triggered arrhythmia, that is after depolarization, and abolish re-entry. Now coming to the first prototype drug in the class 1A, quinidine. Quinidine has been derived from quinine. Quinine is the anti-malarial drug. It is the dextroisomer of the anti-malarial quinine that is found in cinchona bark. Now, in addition to sodium channel blocking property, it has got antivagal property. So, what does antivagal property do? Antivagal means basically atropine-like. So, what it will do? It will basically increase. So, it will augment the prolongation of atrial ERP and minimize refractory period disparity of the atrial fibers. AV node ERP is increased. Quinidine also depresses myocardial contractility. So they are basically, they should not be used in patients where congestive heart failure is there. Failure may be precipitated damaged heart. Quinidine increase PR interval as they are decreasing the AV conduction and increase the QT interval. They block myocardial sodium channel in the open state. They also block the potassium channel and thus they are prolonging action potential duration. And they have got weak alpha adrenergic blocking action. So their usage can cause hypotension. They have got anti-malarial action as well as the quinine. They show chinkonism as a side effect, that is ringing in the ears, dizziness. So that is also shown by quinidine. They cause ringing in ears, vertigo, deafness, visual disturbance and mental changes termed as chinkonism. Quinidine drug interactions, rise in blood levels and toxicity of dioxin by displacing it from the tissue binding site, as the drug has got weak alpha adrenergic blocking action. So when combined with other vasodilators, profound hypotension may be seen. Risk of torsades de pointis is there because of hypokalemia caused by diuretics, and they have got synergistic action with beta blockers, verapamil and potassium salt. Uses, they can be used in many types of atrial and ventricular arrhythmias. Risk of adverse effect is there including torsades de pointis that can cause sudden cardiac death. Procainamide, it's basically the derivative of procaine, local anesthetic. Difference between the two, that is a procainamide and quinidine, are the cardiac depression property is very less compared to the quinidine. It is less effective in suppressing ectopic automaticity. Antivagal action is not there and it is not an alpha blocker. It is metabolized by acetylation to N-acetyl procainamide, NAPA, which has no sodium channel blocking property, but they block potassium channel and prolong the action potential duration. Procainamide is occasionally used to terminate monomorphic ventricular tachycardia and some supraventricular tachycardia. Coming to disopyramide, it again show a cardiac depressant and anticholinergic action. Because of the anticholinergic action, it can cause dry mouth. It has got no alpha adrenergic blocking property, so hypotension is a lesser risk with disopyramide. Contraindications are sick sinus syndrome, cardiac failure and prostatic hypertrophy. It is the second line of drug for basically preventing the recurrence of ventricular arrhythmias. Coming to subclass 1B, they are sodium channel blockers with channel recovery very quick, less than 1 second. Lidocaine is the prototype drug in the subclass 1B. They do not depress the AV conduction or prolong action potential duration, ERP QT, unlike class 3 and class 1 drugs. Lignocaine is primarily used as a local anesthetic and is also a very good antiarrhythmic drug in the critical care setting. It is relatively selective for the partially depolarized cell and those with longer action potential duration because it does not affect the action potential duration. The most prominent action is suppression of automaticity in ectopic foci. Well, lignocaine is the drug of choice in ventricular arrhythmias, ventricular tachycardia. It shows high first pass metabolism in liver and they have got very rapid redistribution. Because of rapid redistribution, the high first pass metabolism is dependent on the hepatic blood flow. Now propranolol, they decrease the hepatic blood flow. So use of propranolol with lignocaine, that can increase the concentration of lignocaine in the body. Now the side effects, the main toxicity is neurological like paresthesia, drowsiness, nausea, blood vision. It is the least cardiotoxic antiarrhythmic drug. It is used to suppress ventricular tachycardia and ventricular fibrillation. It is a very good drug in the emergency setting, patient presenting with ventricular tachycardia. Why? The action is quick and the action is titrable with the titration of the dose. They suppress ventricular tachycardia due to digitalis toxicity, but they have got no action in the supraventricular arrhythmias. Coming to subclass 1C, is more basically they close the open state sodium channels and the recovery time is longest, more than 10 seconds. They have got high pro-arrhythmic potential. Sudden death have occurred with the use of subclass 1C. Propafenone. Propafenone basically they have got profound action on the His-Purkinje fibers and on the accessory pathway conduction. So they are helpful in basically re-entrant tachycardia including WBW syndrome. They prolong action potential duration and they have also got beta blocking property. Now they are metabolized by CYP2D6 isoenzyme. Now this enzyme shows pharmacogenetic property. They are extensive CYP2D6 metabolizers and they are poor metabolizers of CYP2D6. Now it can worsen congestive heart failure because of cardiodepression property and increase the risk. They are used for prophylaxis of the ventricular arrhythmias including treatment. They are used for re-entrant tachycardia. Now coming to class 2 basically are beta blockers. They are used for sympathetically mediated arrhythmias. Now propranolol, it is the most commonly used basically beta blocker as an antiarrhythmic drug. Now the antiarrhythmic action is exerted primarily because of cardiac adrenergic blockade. Now how does it act? Basically they are decreasing the slope of phase 4 depolarization and thus they are decreasing the automaticity of the SA node, AV node and other pacemaker cells. Again on the AV node they are prolonging the effective refractory period. So AV conduction is slowed down. They are useful in paroxysmal supraventricular tachycardia. They are useful in the controlling the ventricular rate of atrial flutter and atrial fibrillation. They are useful in inappropriate sinus tachycardia, but in PSVT they are less effective than adenosine and verapamil and diltiazem. Now, drug of choice in PSVT. Drug of choice in PSVT? Adenosine, right. So propranolol, it really in a patient of atrial flutter and atrial fibrillation, they are not curing the arrhythmia. Thus, beta blockers, they control the ventricular rate. Digitalis induced tachyarrhythmias may be suppressed by the drug. Non-sustained VT, beta blocker may be used, but they have got, but they do not show any activity in sustained ventricular tachycardia. There the response is poor. In the post-MI patient, beta blockers may be used as a prophylaxis to prevent the arrhythmias and sudden cardiac death. Sotalol is basically a class 2 drug that is a non-selective beta blocker, but they are also showing class 3 property. So they are blocking also potassium channels, delayed rectifier potassium channels. As they are blocking the potassium channel which act in the phase 3, they prolong the action potential duration and ERP. They delay AV conduction. They are effective in polymorphic ventricular tachycardia, in the WPW arrhythmias and in maintaining sinus rhythm in AF and AFL patients. They are contraindicated in patients with long QT interval because they are prolonging the action potential duration. Esmolol is the shortest acting beta blocker. So they are used in emergency setting to control the ventricular rate in the atrial flutter, atrial fibrillation and PSVT patient. The quick and short acting beta 1 blocker, emergency control of ventricular rate it can terminate supraventricular tachycardia and is mainly used for arrhythmias caused by the anesthesia like halothane. So what are the class 1 drug antiarrhythmic drugs? জোরে বলো কি বলবে উপরে অ্যান্টিঅ্যারিথমিক ড্রাগ কতটা ক্লাস আছে হ্যাঁ খুব কমনলি কিন্তু অ্যান্টিঅ্যারিথমিক ড্রাগের নামগুলো জিজ্ঞাসা করবে কি কি ক্লাস রয়েছে অ্যান্টিঅ্যারিথমিক ড্রাগ ক্লাস 1 আছে ক্লাস 2 আছে ক্লাস 3 আছে ক্লাস 4 আছে ক্লাস 1 সোডিয়াম চ্যানেল ব্লকার ক্লাস 2 বিটা ব্লকার্স ক্লাস 3 potassium channel blockers like amiodarone and class 4 is calcium channel blockers. Anti-arrhythmic drug আসলে কিন্তু ড্রাগস এর নামগুলো জিজ্ঞাসা করবেই ধরে রাখুন আর ক্লাস ওয়াইজ বলতে হবে so class 3 anti-arrhythmic drugs they are blocking the potassium channels so they are prolonging the repolarization phase that is the phase 3 action potential is widened and effective refractory period is increased. So they are useful in re-entrant arrhythmias. Now coming to the prototype drug in class 3 amiodarone. Number one thing is it is iodine containing drug. As it is iodine containing drug, they alters the thyroid function. They commonly cause hypothyroidism, goiter and rarely may cause hyperthyroidism. They block the conversion of T4 to T3. Number 2 is it is highly lipophilic. As it is highly lipophilic, the absorption is slow and it shows very high distribution. It gets deposited in the adipose tissue. So they have got very half long life. Number 1, they prolong action potential duration and QT interval as they are blocking potassium channels. They preferentially blocks inactivated sodium channel. So it has also got class 1 action like lidocaine or basically class 1B action. They partially inhibit myocardial calcium channels, class 4 action. They have got non-comparative beta blocking property, they have got class 2 action also and they alters the thyroid function. So it is a multi-channel blocker with some additional activities. Conduction is slowed, ectopic automaticity is decreased, but that of SA node is only slightly affected. Now as it is highly lipophilic, it accumulates in the muscle and fat from which it is slowly released and then metabolized in liver. So they have got very high half-life, 3 to 8 weeks. So when we give the drug, we have to give a loading dose so that the action can be started quickly. It is effective in both supraventricular and ventricular arrhythmias including PSVT, nodal tachycardia, ventricular tachycardia, atrial fibrillation and atrial flutter. Resistant VTs and VFs can be helpful with amiodarone. It is also used to maintain sinus rhythm in atrial fibrillation. Rapid termination of VT, VF and supraventricular arrhythmias can be done by using intravenous amiodarone. WPW tachyarrhythmias is terminated by suppressing both normal and aberrant pathway. Long duration of therapy, long duration of action, so they can be used for chronic prophylactic therapy. It's a commonly used antiarrhythmic. Adverse effects are dose related and increase with duration of therapy. What are the adverse effects? It can be fall in BP due to rapid IV injection. Fall in BP is seen only in intravenous dose, not with the oral dose. Bradycardia, myocardial depression on intravenous injection. There can be photosensitivity and sunburn in 10% of the individual. Corneal microdeposits can be seen with the prolonged therapy, but that is reversible. And very important, pulmonary alveolitis and pulmonary fibrosis. It is the most serious toxicity of prolonged use of amiodarone, but it is not seen if it is used in lower dose, less than 200 milligram. Peripheral neuropathy can be seen, goiter, hypothyroidism and rarely hyperthyroidism. may be seen with amiodarone as it is iodine containing and basically alters the function of thyroid gland. Coming to dronedarone, is the class 3 antiarrhythmic, but it is not iodine containing. As it is not iodine containing, it does not alter the thyroid function. So it's a non-iodinated congener of amiodarone. It's a less effective class 3 antiarrhythmic compared to the amiodarone. Maintenance of sinus rhythm in hemodynamically stable patient of basically paroxysmal or non-permanent AF. It is not indicated in permanent AF. To control the ventricular rate, they are also using supraventricular arrhythmias. They inhibit delayed rectifier potassium channels, inward sodium channels and L-type calcium channel like that of amiodarone. Beta adrenergic blocking property is more marked compared to amiodarone. It is less lipophilic and metabolized by CYP3A4-2D6. The risk of torticollis depointis is low. Hypothyroidism, pulmonary fibrosis, peripheral neuropathy are not seen with dronedarone compared to amiodarone. Contraindicated is heart failure, AV blocks and permanent AF. 4, they basically block the calcium channel. Now, calcium channel kothay use ache in cardiac action potential. In cardiac action potential, calcium channel kothay role ache. You have read that in pacemaker cells, they show slow response channels, and here instead of in phase 0, instead of sodium channel, calcium channel is there. Calcium channel opens up. So, because of the use of calcium channel, their action is more on the slow channel response, that is in the pacemaker cells. So, it blocks L-type calcium channels and delays their recovery. It depresses calcium mediated depolarizations. It suppresses automaticity and re-entry dependent on the slow channel response. Phase 4 depolarization in SA node is decreased. So, there is bradycardia. Reflex sympathetic stimulation can be seen because of vasodilatation. The calcium channel is present in the blood vessels that result in vasodilatation and fall in BP. So, reflex tachycardia may be seen, and the direct bradycardia can be seen because of depression of the SA node. Delayed after depolarization in Purkinje fibers are dampened. There is prolongation of AV nodal ERP, and AV nodal conduction is delayed, PR interval increase. Additionally, they have got negative inotropic action. It is useful in preventing and terminating the attack of PSVT. It is used to control the ventricular rate in atrial flutter, atrial fibrillation. They are useful in re-entrant supraventricular tachycardia and in nodal arrhythmias. They have got poor efficacy in ventricular arrhythmias. In fact, in some VT may be converted to VF and sudden cardiac death. It is not recommended for digitalis toxicity as AV block may increase. It is contraindicated in partial and complete heart block and in 6 sinus syndrome. Diltiazem, difference between diltiazem and verapamil কি বলতে পারবে? দুটো তো একই আছে, নন ডাইহাইড্রোপাইরিডিন ক্যালসিয়াম চ্যানেল ব্লকার্স। ডিফারেন্সটা কি? ব্র্যাডিকার্ডিয়া লেস প্রমিনেন্ট, কার্ডিয়াক ডিপ্রেশন প্রপার্টি ভেরাপ্যামিল যতটা আছে তার থেকে কম আছে এটা। So it can be used in heart failure even. So it is an alternative to verapamil for termination as well as prophylaxis of PSVT. The direct cardiac action of diltiazem are similar. However, bradycardia and depression of cardiac contractility is lower compared to verapamil. For rapid control of ventricular rate in AF or atrial flutter, IV diltiazem is preferred over verapamil. Now coming to arrhythmias, in paroxysmal supraventricular tachycardia, how to treat? Drugs কি আছে in PSVT? কি drug use করতে পারি? adenosine আর digoxin আর Beta blockers are calcium channel blockers like verapamil, diltiazem. In a patient of paroxysmal supraventricular tachycardia, first we try non-pharmacological treatment. Why? We know that vagal activity, increased vagal activity, they depress the AV conduction. So, we use Valsalva manovir, carotid sinus massage. Even if with use of these non-pharmacological measures, if PSVT is not controlled, then we go for pharmacotherapy. Now the drug of choice is adenosine. Alternatively, we can go for intravenous verapamil, that is verapamil diltiazem, esmolol or propranolol, and additionally we can combine digoxin if required. Drug of choice is IV adenosine. To prevent the recurrence, oral therapy with calcium channel blockers, beta blockers or digoxin can be used. Now coming to adenosine. Adenosine is not included in any of the class. Now how they act? They block the acetylcholine sensitive, they activate the acetylcholine sensitive potassium channels. Now their action is very brief. The T half is around 10 seconds, I think so. T half is around 10 seconds. So in one's coronary circulation time, the drug is redistributed in the endothelial cells and the action winds off. So the drug has to be administered intravenously to control the arrhythmia in the larger vein. Okay. It is administered by rapid IV injection over 1 to 3 seconds. It is available either as free base adenosine or as ATP. If we use as free base, 6, 12, 18 milligram are the dose as required. If we use it as ATP, 10 or 20 milligram. Now adenosine terminates the tachycardia within 30 seconds. Now how does it is acting? It is activating acetylcholine sensitive potassium channels. It is acting at the A1 type of adenosine receptor present in the AC node, atrium and the AV node. In the AC node, basically it is causing bradycardia. In the AV node, it is causing slowing of the conduction, and in the atrium, it is causing shortening of the action potential and reducing excitability. It indirectly reduces calcium current in the AV node. Adenosine has got very short T half 10 seconds due to uptake into the RBC and endothelial cells. Now dipyridamole, basically they potentiate the action of adenosine by inhibiting the uptake, and theophylline and caffeine, they antagonize its action by acting on the adenosine receptors, by blocking adenosine receptors. So adenosine may not act in the heavy tea or coffee drinkers. Advantage of adenosine in terminating PSVT, why the drug of choice? Efficacy equivalent to or better than verapamil. Where verapamil cannot act, adenosine will act. Action lasts less than 1 minute. Adverse effects like even cardiac arrest can occur only for a few seconds and patient may not feel. No hemodynamic deterioration and can be used in patients of hypotension, congestive heart failure or receiving beta blockers where verapamil cannot be given. It is safe in wide QRS complex tachycardia where verapamil cannot be used. It is effective in patients not responding to verapamil. Now, side effects are transient dyspnea, chest pain, fall in BP, flushing. Ventricular standstill, cardiac arrest can occur, but it is transient and patient may not feel the event. Bronchospasm can be precipitated with the use of adenosine. We know adenosine receptors are present in the bronchial tree. Verapamil is a drug of choice for such patients. Now adenosine has to be rapidly injected into a larger vein and has got very brief action. It is not suitable for prophylaxis because बारे बारे किंतु इंट्रावेनस देना संभव नहीं. Drugs for AV block, atrioventricular blocks, generally we treat the patient if it is permanent or chronic with the pacing, cardiac pacing. But it can be used in a case of acute event of AV block or when the cardiac pacemaker has to be inserted, but certain time we require. In that case, the two drugs are there, atropine and sympathomimetics, that include isoprenaline. Now, atropine is used when AV block is due to vagal overactivity. It can be used at a dose of 0.6 to 1.2 milligram intramuscular or IV. Isoprenaline can be used to overcome the partial heart block by facilitating AV conduction and shortening ERP. Isoprenaline is sometimes complete heart block where cardiac pacemaker is required to buy time in the entering. Now, these are the different arrhythmias like atrial extrasystoles, atrial ectopics. Now, if these are not cumbersome, not symptomatic, in that case we do not treat the arrhythmia. Now, if it is symptomatic or symptom relief is required, then beta blockers can be used like propranolol. Paroxysmal supraventricular tachycardia, we require termination of attack. We want to prevent the recurrence. So there, for acute termination of attack, intravenous adenosine, verapamil, diltiazem, esmolol can be used. For preventing the recurrence, verapamil oral, diltiazem, propranolol, sotalol can be used. Coming to the atrial fibrillation, it can be treated in a two way. One is converting the atrial fibrillation to sinus rhythm, that is cardioversion, and number two is controlling the ventricular rate. Now, this reversal to sinus rhythm can be done in paroxysmal AF or persistent AF, while controlling the ventricular rate is needed in permanent AF. Now, how we can revert to sinus rhythm? By intravenous amiodarone, sotalol, propafenone, amiodarone, dronedarone and others. For controlling the ventricular rate, digoxin is there, calcium channel blockers are there, beta blockers are there. Atrial flutter is better we convert to sinus rhythm. In atrial flutter, we can control the ventricular rate like that of atrial fibrillation, or we can revert to sinus rhythm. Wolff-Parkinson-White syndrome, radio frequency ablation is the treatment of choice, and medical therapy we can go for beta blockers, calcium channel blockers, amiodarone can be used, propafenone can be used. In case of acute MI, bradycardia, atropine and followed by pacing. In case of acute MI induced ventricular extrasystoles and tachycardia, lignocaine is the drug of choice, intravenous lignocaine. Alternatively, amiodarone and procainamide can be used. Chronic ventricular tachycardia non-sustained, beta blockers can be used like propranolol, amiodarone can be used. In sustained VT, amiodarone can be used. Ventricular fibrillation, defibrillation can be used, amiodarone can be used and beta blocker can be used.